Good afternoon. I'm Dr. Jang Baek in Seoul, Korea. I thank everyone for giving me an opportunity to present here, but we don't have much time. I have to jump into the topic right away. I don't have any conflict of interest to be disclosed. Let's begin with the real case. This is a common case with a left middle cerebral artery. What do they have to do this occlusion? It may be easily and completely recanalized only by one stent retrieval passes. It may be less than 30 or 20 minutes to get a successful recanalization. Or after the first passage of stent retrieval, you might see the tight or severe stenosis in the middle of the middle cerebral artery, and it will be finally re-occluded again and again. You might have to consider to use some drugs such as tiotropium or perform angioplasty when intracranial stenting. For the same middle cerebral artery occlusions, the procedure and its result can be totally different. And the occlusion path mechanism is critical for the difference. We need to determine occlusion path mechanism correctly. Among a few occlusion path mechanisms, today we are focusing on the ICAS ELVO. So, how can you confidently identify the ICAS ELVO? Today, I'm going to review and introduce some of clinical and imaging features of the ICAS ELVO. Okay, let's talk about the clinical features of the ICAS ELVO first. I think everyone can agree that relevant risk factors for atherosclerosis can be associated with acute ICAS ELVO. Also, patients without any embolic sources can have a higher possibility for ICAS ELVO. So, I summarized all reports of comparison studies of ICAS ELVO. As what you can see in this table, some clinical variables were significantly different, but the significance of these clinical variables are dependent on the study population or the designation of the study. However, younger age, male, less severe stroke, nerve artery fibrillation, hypertension, diabetes, and dyslipidemia were consistently regarded as a main difference in the 3 studies. So, can you predict the ICAS ELVO with these clinical variables? I think the most important problem is that the clinical features are just supportive, not decisive to predict the ICAS ELVO. I think we have to use other more specific findings to suggest the ICAS ELVO. In prediction of ICAS ELVO, imaging findings can be more specific than the clinical features. Until now, many imaging findings were reported to suggest ICAS ELVO. Some findings can be observed during the procedure, or some of the findings can be identified before the procedure. If you are familiar with these findings, I think it will be so helpful in your determination of occlusion path mechanism. I will introduce these findings one by one. The first finding is the significant fixed focal stenosis. It is very intuitional and is to be found. If you encounter kind of focal stenosis that forces to the end of a procedure, or in some cases to follow angiography, it can be a fixed focal stenosis. It was firstly organized and reported in 2015, and it has been widely used as an operational definition in most of the researches of ICAS ELVO. To define the ICAS ELVO, the fixed focal stenosis should be significant. By its original definition, Their stenosis degree more than 70%, or moderate stenosis with a perfusion impairment or Leo occlusion tenderness can be significant. One of the important steps that should be emphasized is that some specific etiologies such as dissection, iatrogenic injuries, and myomatosis and vasculitis should be excluded, and complete recanalization without residual stenosis, and it can be maintained on follow-up. It can be suggesting an embolic occlusion. To exclude peri-procedural conditions confused with fixed focal stenosis, one should wait for a while, 10 or 20 minutes after recanalization. So, detailed steps to define ICAS AAFITN based on the significant fixed focal stenosis was reported in one living article. The review article was written by original author Dr. Jin-Soo Ri. I think the article can be so useful to everyone in diagnosing the ICAS AAFITN and its research field. The next finding is the truncal type occlusion. Truncal type occlusion is one of occlusion type which was derived from a hypothesis based on a simple physical rule. Let's think of an embolus or a clotting thrombus. When the embolus is applying, it seems possible but so unnatural for the embolus to be halted in the middle part of a normal artery. Instead of that, I think it seems more natural for the embolus to be lodged at its bifurcation site or branching site. So we hypothesized that the occlusion, which doesn't involve a branching site, could be a predictor of non-embolic occlusion. Also, we hypothesized that endovascular details are different according to the occlusion type. Finally, we thought that the truncal type occlusion can be a surrogate marker of non-embolic, specifically ICAS-related occlusion, and its procedural results and details are very similar to that of ICAS AAFITN. Before I will show you the demonstration of the hypothesis, let's discuss how to define the truncal type occlusion. The essential point in determining truncal type occlusion is to verify the intact branching site. In this example, internal carotid artery bifurcation site is saved, so contralateral flow was passed through ventral communicating artery. This means that the occlusion is located below the bifurcation site. Without the cross-collateral flow, we can see whether its bifurcation site is intact by deployment of stent retriever, microcatheter angiogram, or after partial or minimal spontaneous recanalization. Among them, the deployment of stent retriever is the most common situations you can identify the occlusion type. In contrast to the truncal type occlusion, the bifurcation site is not visible in branching site occlusion. It means that the occlusion segment involves the bifurcation site where the embolus is likely to be lodged at that area. For an example, if we deploy the stent retriever, temporary border flow only can be shown to one major branch. So now we can call it a branch missing site. This can be also observed other than by arterial configuration. In capillary phase of distal obstruction angiography, for the part that its relevant artery is not temporarily recanalized, converse stain is not seen. So-called angiographical territory filling defect. This can be an alternative finding for the branch missing site. In truncal type occlusion, embolic sources were significantly less frequent. Also, stent retrieval was less successful in truncal type occlusion. The odds ratio of the truncal type occlusion for the failure of stent retrieval treatment was more than 30. The procedural details in truncal-type occlusion was very similar to that of ICAS AAFITN, especially the frequency of the occlusions and the necessity of ICAS-specific modalities were remarkable. And successful rate of stent retrieval in truncal-type occlusion was nearly 20%. Here is an example. A male patient had acute left middle cerebral occlusion. After one pass of stent retrieval, the occlusion was recanalized, but immediately reoccluded. In fact, the occlusion was truncal type. As depicted, the occlusion segment was before the bifurcation site and did not involve the bifurcation site. To overcome the intractable recurrent reocclusions, we permanently detached the stent retrieval device. The occlusion type can be determined before endoscopic procedure. On the pre-procedural CT angiography, we often see the intact bifurcation site beyond the occlusion segment. And pre-procedural determination of occlusion type by CT angiography was as accurate as by BSA. More interestingly, when we compare the CT angiography-based occlusion type with other common pre-procedural findings suggesting occlusion path mechanism, occlusion type was significantly superior in predicting stent retrieval successfully. It was superior than the presence of atrial fibrillation or hyperdense artery sign. Even in patients with atrial fibrillation and hyperdense artery sign, if the patient has truncal-type occlusion, stent retrieval success was merely 50%. On the contrary, when the patient has branching site occlusion, although without atrial fibrillation and hyperdense artery sign, stent retrieval could be successful in 75% of patients. Let's look at some typical examples. A young man has acute right middle cerebral artery occlusion, and even before starting the endoscopic procedure, we don't have any clinical information. He didn't show any atrial fibrillation or hyperdense artery sign. On CT angiography, the occlusion was branching site occlusion. Also in the assay, it was branching site occlusion too. The occlusion was completely recanalized by just one pass of stent retrieval. After the procedure, we could get more medical information that he had an artificial heart valve and had received warfarin, but discontinued recently. In another case, respiratory type was saved, but atrial fibrillation was observed in emergency room. Her occlusion was initially treated by angioplasty, but not significantly maintained. So finally, her occlusion was treated by permanent stenting and additional ICAS-specific modalities. We think her AP was likely a bystander, and imaging finding was more specific to the occlusion path mechanism. These are some illustrations from articles reporting cases with ICAS AAFITN. Please see how about the bifurcation site. I think only one case does not go with us like this, but all examples have intact bifurcation site, and most of the cases reported in previous articles were truncal type occlusions. The similar concept was also reported by different groups. One of them was basilar tip opacification. They told that it was perfectly observed in all cases with ICAS AAFITN. Another researchers reported the concept of a post-stent deployment impact. It was exactly the same with our branch missing sign in defining occlusion type. When the stent retriever was deployed, only fluid flow was through one branch, not all branch. And the curve was lodged, you can see, and the embolus is lodged at its bifurcation site. As expected, though, Post-stent deployment effect was significantly associated with non-atrial fibrillation, less effective stent treatment, and finally seen in all cases with ICAS. The third finding to suggest ICAS LVO is the appearance of occlusion border, which means the shape of the most proximal margin of the occlusion segment. All they were recently reported from the last year. The total of 4 articles focused on the association between occlusion border appearance and occlusion path mechanism or endovascular success. The shape of occlusion border in those articles can be summarized like this. Based on the shape observed in the cataract angiography, they were classified into tapered, tram track, curved, and meniscus. Among them, the tapered shape of occlusion border was significantly associated with de-novo hyperdense artery sign, intraprocedural reocclusion, and needle vascular modality. And final complete recanalization was less than non-tapered occlusion. All these findings of tapered occlusion were suggestive of ICAS LVO, and about 80% of tapered occlusion was truncal hypocclusion. However, in another report, tapered occlusion was not associated with occlusion etiology, although its determination of ICAS was much limited as it was the toast classification. Meniscus shape of occlusion border was primarily associated with a successful recanalization or post-pass recanalization. It was more frequent seen in embolic stroke, but it was not directly suggestive of occlusion path mechanism. In one study, meniscus shape of occlusion border on CT angiography was highly associated with ICAS. In conclusion, among occlusion border appearances, tapered and meniscus shapes seem to be particularly meaningful, especially in occlusion path mechanism. The fourth finding is the status of left meningeal collaterals. Physicians have believed that a kind of chronic ischemia such as ICAS makes the left meningeal collateral robust. And in one small unpublished data, patients with ICAS LVO had the better left meningeal collaterals. We recently evaluated this hypothesis among several conditions of left meningeal collaterals. CT angiography-based complete left meningeal collaterals was significantly associated with ICAS LVO. Its predictability of the ICAS LVO was just modest, and the area under the cup value was not so high. But in the same population, its predictability was better than the presence of atrial fibrillation. There was an interesting finding to suggest ICAS LVO after the occlusion segment is penetrated by a microcatheter. Temporal anterograde flow can be seen in ICAS LVO. Also reported this as the first pass impact, and this is very frequently seen in patients with ICAS LVO more than 90% of cases. There are some minor imaging findings for ICAS LVO. Specific impact patterns can be suggestive of ICAS LVO. In summary, infection in deep areas such as basal ganglia or borderline or scar to the impact pattern might be frequent in ICAS LVO. Also, smaller impact volume or higher calcification burden may be associated with ICAS LVO. In another report for basilateral occlusion, long occlusion ranks or proximal or metatarsal occlusion was related to ICAS LVO. Okay, this is the last slide of the presentation. For an optimal endovascular strategy, it is important to determine occlusion path mechanism competently. In clinical features, younger age, male, smoking, less severe neurologic symptoms, absence of atrial fibrillation, and presence of some risk factors for atherosclerosis were rather consistently reported in relation to ICAS LVO. Among several angiography findings, significant fixed focal stenosis, truncal type occlusion, tapered occlusion border, and complete left meningeal collaterals seems relatively more specific to ICAS LVO. Thank you.